Now, are you able to see me now? You cannot start your video. No, but problem is you are written, you cannot start your video because host has stopped it. Okay. Yeah, that's fine. Subhash, can you see me now? Are you able to hear me?
Yes, we can hear you, sir, and I can see you as well.
Okay, right. Now we can start because already late.
Yes, sir, I have still not opened the room. I'll open the room for everybody to enter.
Yeah, please.
So participants are joining.
Yeah.
So I think we can wait maybe a couple of minutes and then start.
Yeah, sure.
Sir, I think you can start.
Yeah. So I'll start. Subhash Kaul, you want to say something? Subhash, are you there? Okay, I think we'll start. Good morning to all of you. This is the 7th session of the challenging case series from the PINE program. And the pattern is just like the previous one. I'll be presenting the case history and findings. And you can ask questions in between. Whoever want to unmute, you can unmute and then ask questions. So we'll go to the, I'm going to share my screen now.
Madhu sir, good morning.
Good morning, Subhash. Shall we start now? Subhash, I'm starting now.
Good morning, Madhu sir.
Yeah, are you able to hear me now?
Yes, sir, we can hear you, and your slides are also visible. You can
No.
move them to the full screen mode.
Yeah, just one problem I popped up now in my this thing. I don't know. Just give me 2 minutes. The slides are not moving now. I don't know. Some problem there.
No, slide moving is in hands of Mansi.
No,
You
no,
don't have
sir.
No, just
So all you have
Mansi,
to do is you have to just click on the slide and then it will move.
okay. Just 1 minute. No, something has happened. I will log out again and then just 1 minute.
sir, Mansi has the ultimate control, which you
Yeah.
also don't know.
Yeah, just a minute.
Mansi, why he's not able to move the slides?
Well, it's my problem. My problem.
That's not- I have nothing to do with that, sir.
देखो मानसी, वो कहते हैं ना उनकी इजाजत के बगैर एक पत्ता नहीं हिल सकता है, तो पत्ता will not move without your permission.
Okay.
Are you able to move the slides now?
No. Yeah. I will just log out and enter again once again. Just 1 minute.
Madhusan's also become expert in these.
Okay.
Till now you are expert in neurology. Now you are expert in webinars also.
Now, can you see my slide now?
Yes,
Okay.
we can see. We can see you also. You are audible, visible, everything.
Okay, now we'll start. So we'll go for the first case. It's a 36-year-old man who came with history of pain below the angle of the left mandible while chewing for the last 6 months. The pain did not increase by coughing or sneezing, not increase by neck movement. For the last 3 months, wife has noticed drooping of the left eyelid as well as congestion of the left eye. Along with this, he also noticed he is not sweating on the left side. On examination, obviously, yes, left Horner syndrome. Rest of the examination is normal. This is a short case. We can see the face of the patient. He has got a Horner's on the left side and mild congestion on the left conjunctiva. And this is the picture brought by him, taken by himself of his face, showing that he's sweating only on the right side. The entire left half of the face is not sweating. This you can see here also. So what do you think the patient is having? And you can unmute. Anyone who want to answer can unmute and answer. It's Horner syndrome, no? Where do you think is a possible site of lesion? He has no other neurological deficit.
Sir, does he have pain also on that side?
Yeah, he had pain while chewing on the left side of the angle of the mandible.
But how old is he, sir?
He's about 35 or so.
And he doesn't have any hypertension or any other.
No, nothing. So in fact, we don't know the cause of the Horner syndrome. So in fact, the MRI brought by the patient was normal. So what other investigation would you like to do in this patient?
Hi.
So the MRI was taken to the upper thorax, neck and base of the skull. This is the thorax CT, normal. Then there's a special sequence of dissection was taken, that's also normal. Then this is the arrow pointed to the middle carotid artery, there is no dissection there. Then I ordered for thin cuts of the brainstem and this sequence to find out if there are missing lesion in the brainstem. There is nothing in the brainstem. My question is to the, and not to Subhash, to the audience, the other participants. Where is the site of lesion in the Horner syndrome in this patient? Is it in the brainstem? Is it in the cervical cord? Or is it in the brachial plexus? Or is it in the cervical spine in the common carotid artery, internal carotid artery, corner sinus, or the orbit?
Was the sweating in any way affected?
Yeah, sweating is affected on the entire face on the left side.
Okay. So it's probably preganglionic.
Yeah, that shows that lesion is can be in the common carotid also, but not in the indel carotid. As Sudhir said, it is proximal to the bifurcation of the common carotid. That means it cannot be in the indel carotid, nor in the cavernous sinus, nor in the orbit. Anywhere proximal to that. That's the site of lesion. So it took the cervical spine was taken, special disc this was taken. Then I again took an MRI of the brachial plexus to find out I'm missing something in the brachial plexus. Now, what else you need now? It's only for last 3 months. Okay, now the radiologist phoned me and told me that there is no lesion I could locate in the to account for the harness. Then I said, no, nothing doing. There is some lesion in the neck. I don't know what it is for your job to find out. Then he said, no, nothing, I haven't done everything. No, you find out, it is your job. Then I did. He searched it again, went back and looked at the MRI. He thought something is odd in the styloid process here. Then he went and took a CT scan. This CT scan shows an elongated styloid process, grossly elongated styloid process. This is seen bilaterally. You can see the styloid process, and it can measure the distance is about 6.3 centimeter. And what point he noticed was that the styloid process on the left side is a little larger and long compared to the right side. And this is structures he found. This inferior vena cava, 3 is inferior vena cava, inferior jugular vein. This is a carotid artery, and this is the carotid sheath, and this is the styloid process. So in fact, it's a case of isolated Horner syndrome from an elongated styloid process called the Eagle syndrome. Eagle syndrome occurs when elongated styloid process causes otolaryngological or neurological symptoms and signs. This is from the literature only. We report a patient who had an isolated asymptomatic Horner syndrome that resulted from a pinned internal carotid artery being dynamically injured by an elongated styloid process during chiropractic neck manipulation. There was no evidence of arterial dissection. This is from the literature again. No, this is it's a short case. I thought I will start with the short case first and go into problem cases later on. Shall we go to the next case? Subhash?
Yeah. So what was done for this patient, Madhu?
I forgot to tell you, this patient was operated and he got a very long styloid process taken out, and he did not improve much. He only showed mild improvement in his deficient Horner syndrome. Even after 3 months, it was persisting like that.
But what happened to the pain on that side?
That subsided. Pain subsided. Everything subsided, but the Horner syndrome was persisting partly, not totally improved. The idea was to prevent a dissection. Prevent a dissection developing later on because of the chronic impingement of the styloid process or the carotid artery.
So my one comment is that we have read about this thing, but in this patient, of course, it is unusual that he had a Horner syndrome. But otherwise, when should we suspect this long styloid process and investigate for it? What are the usual manifestations? Do they have the glossopharyngeal neuralgia or something?
Yeah, the only clue was that he had a pain in the left angle of the mandible while chewing. In fact, that is a symptom they combine in persons with Eagle syndrome.
Okay,
in fact, it did not struck me initially. I thought some problem in the neck and there is a pain. But the styloid process diagnosis never came to my mind. Only the radiologist picked up that finding.
Okay, sir. Thank you.
Yeah. This is another interesting case. 2-3 cases are very interesting, and one is a real challenging case also. This is a story of a patient. Shall I continue? Yeah. This patient is a 60-year-old man who is a chronic alcoholic, developed recurrent vomiting for 2 days and admitted in the local hospital. The serum sodium was 106 at that time, and he was treated in the hospital. What all treatment he received, we do not know. This was in a local hospital. 2 to 3 days later, patient went into altered sensory. The patient was suspected to have CPM, that is central pontine myelinosis, and MRI was taken after 1 week of developing the altered sensory. This is the MRI taken 1 week after the correction of sodium hyponatremia and altered sensory vomiting and all. This is the flyer sequence, which is normal. We did not show any gross abnormality here. Then this is a diffusion, which also is medulla, pons, upper pons, midbrain, thalamic area, basal ganglia region. This is an ADC map. They're all normal. So the patient was put in the ventilatory support along with other supported treatment. CSF was done, which was normal, and patient was empirically put on acyclovir. And the patient condition remained the same. So, for want of anything, just they took an CT scan again. That was again normal. Ultimately, patient could be weaned off on the ventilator, but continued to remain in a comatose state. Examination revealed bilateral rigidity of both upper and lower limb. Plantas were outgoing, and the most important finding is this patient had a very interesting finding in the ocular motor examination. Because this patient is comatose, the eyes were stationary, there is no spontaneous eye movement, no ocular movement, no gaze deviation in either direction, nothing. But look at the video very carefully. When I'm trying to do the ocular capillary, this is the finding. When I turn the head to the left side, stationary, there is no eye movement at all.
Okay.
Turning to the left side, eye goes towards the left. Turning the right side, eye goes towards the right. And it's moving slowly, as if it's moving in a thick oil. Did you see that? Just opposite to what you find in a ocular capillary. It does not move the contraction side to the same side as the head deviation. Quick movements also resulted in movement, the slow movement of the eye. If just the head also is moving. As if the eyeballs are in a thick oil. But this is from the another angle I'm taking from the cranial side. You can visualize the eye movement. It's more detailed. You know, turning to the right, left side, turn to the left side. Remain like that. Does not come back spontaneously. The other side goes to the other side. So that was the finding in that patient. Now, what do you think about that ocular movement? Anyone would like to comment on that? Any residents or anyone can comment on the type of eye movement? No, in fact, this is an alternate gaze deviation precipitated by neck movement. See, there's an entity called periodic alternating gaze deviation seen in lesions above the brain. So that is spontaneously occurring in a person, is usually a conscious patient. Eye goes to one direction, remain for some time, then slowly come back to the other side, remain for some time, 2-3 minutes, then come back. That is periodic alternating gaze deviation. Here, this is also the same gaze deviation, but it's precipitated by turning the head to the same side. So this entity is called what is called the geotropic alternate gaze deviation. In fact, I was not knowing much about these things. Then I read about it. Before coming to that, I will say that what happened to the patient. A repeat MRI was taken 3/8/20, that is 10 days after the first MRI. That's altogether 17 days after the initial loss of consciousness. And this is the MRI in this patient. You can see this is the diffusion showing hyperintensity in the thalamic, caudate, and putamen, as well as in the cortical ribbon area, in the cerebellum also. The brainstem also there is a diffusion restriction. It's also in the claustrum, the claustral area is also hyperintense. So this before what happened to the patient will tell later on. This entity is called geotropic ocular deviation skew in absence of saccade. This is usually described in Jacob-Russell disease, but these cases are all conscious patients. They get deviation when turning the head, and they also develop a skew. Our patient did not have a skew. This from the literature, what I have copied from just from that article. When the head was turned to one side, the eyes very slowly deviated to that side. Cardiac stimulation produced tonic deviation of the appropriate side without nystagmus. At autopsy, one patient showed lesions compatible with pan-encephalitic type of CAD. Although bilateral critical areas had marked gliosis, other nuclei and structures associated with the oculomotor system in the brainstem, including the oculomotor, trochlear, abducent, vestibular, perihypoglossal nuclei, etc., are all preserved. These patients had a supranuclear disorder, probably caused by combined disruption of the direct and indirect frontal light field to the brainstem pathways, plus impairment of superior colliculus mediated saccadic path. This explanation is offered for this type of ocular movement. This shows that the brainstem structures are essentially the oculomotor system is clean. Now, the MRI was repeated again after 1 week later. This shows same finding. Hyperintensity, this is a diffusion showing hyperintensity in the brainstem, midbrain and midbrain pons, and the thalamic, putamen, caudate, etc. And this is the cortical ribboning seen in the even after 1 month. So, what do you think the diagnosis is likely to be in this patient? This particular eye finding has been described only in CJD, not other conditions. But there is no disable. All illness started acutely following a recurrent vomiting, hyponatremia, and correction, and then later on this altered sensorium, rigidity, and then MRI findings of this kind of ocular movement of this kind. In fact, I thought the patient had some kind of a CPM itself. That means hyponatremia correction, central pontine myelinosis, central as well as extrapontine myelinosis. But the odd point was the cortical ribbon that was not described in CPM. The radiologist opined that this is hypoxic cerebral damage, to which I was not agreeing because the patient never went into hypoxia in the hospital. The patient was all throughout in the ventilator, never went into hypoxia. And moreover, brainstem hyperintensity in hypoxia is extremely uncommon. No, I don't know whether it can occur. So what is your opinion in this patient? Subhash, Sudhir? In your opinion regarding this patient?
Oh, did he have fever and all encephalitic type of illness?
No fever. He did not have any fever, headache at the onset. Only thing is we started empirically, the patient started by cyclone.
So it came just out of the blue, this syndrome?
Yeah, he was an alcoholic. So one day he had, I don't know whether occurred about or not, recurrent vomiting for 2 days. And then we did altered sensorium, serum sodium was 109, then treated, and they continued to remain unconscious. That's why he is brought to our hospital later. The first MRI was taken there itself. They did not find anything. They sent the patient over. In fact, I was not knowing what it was. Then I sent the films to this is the player sequence of the same patient. Again, essentially the same finding. MRI.
Can it be some kind of Wernicke's prototype? Because you are saying that he had an alcoholic binge and all.
Yeah, but he was, in fact, we considered that for week he was in the hospital. We gave whatever we had at my right hand. He would never had injection, things like that. We did not improve. And this
Okay.
guy, I do not know. It could be. Nobody can say it's not. It
Yeah.
could be. But this is not the classical finding of the involvement of the mammillary body.
Yeah, not classical.
Yeah,
Right.
that's not here in this patient. The EEG was done even one because seeing that literature in the EEG, we showed diffuse slowing in theta and delta, no spikes, no periodic complexes. EEG was repeated again after 1 week, which also showed no periodic complexes. So I then sent asked Bijoy's opinion. He was a senior professor of radiology, neuroradiology in Sriyatra. He opined that he looks like extended spectrum osmotic dysmyelination, unlikely to be hypoxia. Other different diagnoses were encephalitis like H1N1 and herpes, which appears less likely. In younger patient, we should have considered metabolic causes like aminoacidopathy or biotin-thiamine response encephalopathy. So this is his opinion. Ultimately, I don't know what is the diagnosis, but this is what I thought. But the case was brought because of the very interesting ocular finding, which I never seen in my life before. For turning the head, the eyes go to the same side in a slow motion.
But Madhu,
Yeah.
I mean, it's a very, very interesting patient.
Yeah.
And osmotic demyelination, this is not the typical radiological picture, no, you know, that with thalamus and all that thing. Usually they have mostly in the either pons or basal ganglia and all this. It's not a typical. But I'm just thinking aloud, Madhu, that if you take Wernicke's, after all, Wernicke's also may not involve only mammillary bodies. It can involve surrounding areas also. And then Wernicke's also you get eye movement dysfunction. Not necessarily this, but they do involve eye movements.
Correct. Perfectly right. Yeah.
So it may be some kind of a cousin of Wernicke's, if not exact.
What you said is perfectly right, because I had a patient who had Wernicke's encephalopathy, typical, following she had chemotherapy drugs for ovarian carcinoma. Later on went into CPM. So they are cousins. So this patient, even literature, they have said that a patient with CPM can go on to Wernicke, or Wernicke can go on to CPM. These are well described.
Because setting, Dr. Madhu, setting.
Perfectly right. You're perfectly right.
Yes, sir.
I think that's a very good possibility. I also agree with you. Perfectly right. That the cousins are there, right? Perfectly agree. So shall I go to another case now?
Yes, sir. Yes, sir. Very good. Very good case.
Thank you. Now, this case, I think people have to concentrate a little bit. Is a little difficult case. Now, this high mental function case. You can interrupt me at any time and ask questions regarding what I thought this patient had. This 64-year-old man was brought with history of memory loss for the last 6 months. Memory loss, quote unquote. You may not understand Malayalam, so after showing the video, I have written whatever question I asked, I have written in English. Now I am basically asking, I have kept 3 things on the table and asking him to point out what all things are, 4 things. One was a watch, one was a pen, one was a key, the other was a coin. Coin you are not able to see. No, it's what he pointed out the watch and said watch. Pen, he said pen. Key, he could not say, probably that the key is not the usual key which you must have seen earlier. But coin, he said kashi. Kashi means in Malayalam coin. Okay, so he named all the 3 objects correctly. Okay, now he said watch, pen, and coin. Okay, that's the first step. Now let us see the second video. I am asking to pointing to the showing a pen, asking him what it is used for. Again, I will give the other thing also. He did not answer anything. Asking what is it used for? Is it a paper? Is it a pencil? Or is it a cup? He did not say anything. So I'll show this question and answers now. So is it a brush? No reply. What is it used for? Is it can be used as a brush? Is it a paper? No answer. Can be a paper. Is it a pen? He said, can be used as a pen. Is it a spectacle? He said, can be used as a spectacle. Is it pen? Again, no answer. Okay. So I was asking the questions like this. He did not reply. He answered, whatever I said is repeating, can be like that. This is the answer. Okay. Now I'll stop here and ask what could be the problem here. Problem could be, is it anomia? Unlikely, because in anomia, the recognition is normal. Here he could not recognize the object. He said, what is it used for? He was not able to tell what is it used for. Nor who could be name it. So a person who does not recognize cannot name properly also. But there is one caveat in that patient. When shown initially, he named the objects correctly. When he was placed on the court, he named initially. But when he asked, what is it? Is it a pen? Is it a paper? He could not say what it is. I'll come to that later again. So here, anomia is a naming problem, but a diagnosis problem. So more likely, he did not name the object since he could not recognize it. Then the question now comes, why did he name them initially by seeing the object in the first video? Can one name the object without recognizing it? That's a question. I'll come to that later again. The answer is yes, one can name an object even without recognizing what it is. That is the ability to name an object with the stimulus features alone, without understanding the meaning of the object also one can name. The next problem, he named the objects initially, but later when he was asked, is it a pen, he could not name. See, if he has got he has no naming problem, then why is not that when he asked his own name, is it a pen, he could not name it? Why did a person who named the object initially could not name them when asked later, is it a pen? That means that the memory of the name bank in the brain is intact, but could not understand the spoken word pen is given. That means he has got a single word comprehension. So that alone is not the problem. I'll come to that again once again. So the point I'm trying to, initially he named it, but could not recognize the object. That means the naming component is intact. The recognition component is lost. The next common problem is that he named by his own by seeing the object. When I shown him, is it a pen? Is it a pencil? He could not understand what I am stating. So that means that he has also got a difficulty in comprehending my spoken word. That is a single word comprehension problem. Apart from his recognition problem, that I will come later. Now the next problem, he is not able to recognize the object visually. Is it a visual agnosia? Could be. Is it a semantic memory loss, that is semantic associative agnosia? Again, it is possible. So now let's see the next video, how to differentiate between these two. I'll show the next video. Here what I am showing is that I am asking to show the object what it is. He was not able to say. He is able to feel it. Still he could not identify it. I shown the pen. He could not say what it is. I am asking to use. He could not say what use it is. Again, asking to feel it. He could not say, identify the object. Again, watch. He could not. Now I'll show the questions I asked. If it was shown the coin, what is it? No answer. He was allowed to feel the object. What is it? Again, no answer. If it was shown a pen, what is it? No reply. He was allowed to feel the object. What is it? No answer. If it was shown a watch, what is it? No reply. What is it used for? No answer. He was allowed to feel the object. What is it? No answer. What is it used for? Again, no answer. Is it used for writing? Again, that means you could not recognize the object either by vision nor by feeling or some of the sensory input. So is it visual agnosia? No, he could not recognize the object even by palpating it. So it is not a visual agnosia only. If it is a gnosis problem, that means the two possibilities we considered is unlikely to be visual agnosia alone. It's a semantic memory loss or semantic associative agnosia. But the possibility of him having both visual and tactile agnosia cannot be totally ruled out, because that's a possibility. You can say both agnosia are there, but logically it is more like a semantic loss rather than individual agnosia between the various modalities. Now let us see this picture. When a picture or the word key is shown or heard or by touch, it leads to recognition through various modalities. Through vision modality, by seeing the key or seeing the written word key, it accesses the semantic store and bring out the recognition. Through the auditory modality, the heard word, that is the key, or the sound of the key, jingling sound of the key, reaches the auditory modality, can reach the semantic store and recognize certain recognition. The third one is touching the key by somatosensory input. So through the somatosensory modality, which is semantic store. In all the three modalities are lost, that means it is equivalently loss of the semantic store. So what is happening in our patient? So in our patient, visual modality input is lost, somatosensory input is lost. More likely it is the semantic store rather than an associative agnosia in this patient. So more like a lesion is here. And one is able to name, once it's reached the semantic memory loss, you go to the lexicon. It made us possible to name what the object after recognizing. Now the next question is, then how did he name the object initially spontaneously without recognizing? The same question which he asked initially. To understand this, I will spend 2-3 minutes to understand what is the gnosis model or how do we recognize and name an object. See, if you look at the steps in visual recognition, the recognition object is through some sort of a symbolic representation. And there are 3 stages of symbolic representation. One is a primary sketch. Second is a viewer-centered or 2-dimensional sketch. Third is the object-centered or 3-dimensional sketch. The first step is the primary sketch, which involves the visual stimuli and initial visual analysis. It's just primitive representation comprising the brightness, intensity changes, contour, etc. Once it has primary, the visual perception, the initial part is normal, the visual perception is normal. Then what is called apperception, that is the synthesizing the various stimulus features. This takes place in 2 steps. One is the viewer-centered representation, in which the object is seen or represented in the brain as the images formed on the retina. That is a 2-dimensional sketch. That is objects represented from the viewer-centered frame of reference. In this representation, if a line is shown like this, he'll be able to say it's a line. But if a line is shown like that, we will not be able to say line. Because to recognize the line in this picture by the side or from behind, you should have a 3-dimensional perception or 3-dimensional representation should be there. That is not possible in the viewer-centered representation. From the viewer-centered representation, input goes to the object-centered representation. That is 3-dimensional sketch, which coordinates the shapes and features as they are related to one another, as the object-centered frame of reference. Putting in other words, this representation gives the object shape constancy, by which we mean that we are able to recognize the object in whatever way it is presented. Even if you rotate it 180 degrees, you can recognize the object. In whatever the lighting condition, you can recognize the object, because your brain has formed an object-centered representation. So that is a 3-dimensional sketch. From the 3-dimensional sketch, then up to this is the level of perception, complete perception. From there, it has go to this, whatever is synthesized, stimulus is synthesized, as goes to the semantic conceptual field or semantic store or memory bank to match the output of the perceptual processing with the representation of the same object which you had seen early in your life is stored in the vision memory. And that is the matching of the stimulus. Once it has reached the semantic conceptual field, you have to give meaning to the stimulus, what it is, what is used the object. That is the meaning of the stimulus. That is where the semantic conceptual field. From there, then ultimately you have to name the object. From that, after recognizing it, go to the phonological lexicon. That is the language area, the normal name is here. But remember, you can also name without recognizing through a direct connection from the objects and their representation or from the perceptual field to the phonological lexicon. Now, if the patient is, let's say the disease affecting one is object agnosia, which you all know, the agnosia word meaning is percept without meaning. It will enable to recognize through one modality. There are two types, apperceptive agnosia and associative agnosia. Apperceptive agnosia is not a true agnosia. You've got normal visual acuity, brightness, discrimination, color vision, but they are unable to integrate the visual information into a detailed structural description of the stimulus. Putting in other words, unable to synthesize individual features like contour, color, depth into an integrated whole. Their shape discrimination, therefore, is defective. So the problem in the model is that an input from the primary sketch to the viewer-centered representation is lost. So that is where the apperceptive agnosia occurs. How do you diagnose it? They are seeing it but unable to trace an object, copy an object like this. They copy letters like that, they copy like as shown in the picture. If you are unable to match, if you are able to match a diamond with the other series of symbols there, they are unable to pick out the correct correct symbol from the array of the symbols which is shown. They are not able to match. That is apperceptive agnosia. Now, the perceptive categorization deficit is another form of apperceptive agnosia, where even though they are able to recognize object through conventional or usual view, they are not able to recognize when shown from unusual views, but can recognize them only when present in the same conventional orientation. For example, a bucket is shown here like this. He'll be able to say bucket without any problem. But if it's shown from another angle, that means he will not able to recognize it's a bucket. That means he has lost his object shape constancy as the model told. That means the input has not gone to the viewer-centered representation, the two-dimensional sketch, but from three-dimensional or object-centered representation is not reaching. That is a perceptual categorization deficit. Now, the true agnosia is associative agnosia, where the patient is unable to identify objects visually with the normal perception. So, where should the lesion? Lesion is there, where the percept is normal, but they cannot reach the memory bank through this input, that is visual associative agnosia. There are two types of associative agnosia. One is a semantic excess agnosia, that is a true agnosia. There is semantic agnosia, which actually should not be called as agnosia, because where the memory representation itself is destroyed. It is not a true agnosia, but it's a category-specific memory loss. The memory loss only for that visual objects, memory not for other objects, or other heard sounds, or other palpated sounds. They are all intact, but memory for this alone is lost. Now, here should be a semantic conceptual field loss. That is where the meaning to the visual stimuli is lost. That is a semantic loss and not true agnosia. So what is happening in our patient? Our patient is having a lesion in the semantic conceptual field because he could not recognize it through other modalities as well. Because here is here not only through the visual field, but the other aspect also is not able to arrive at the meaning of the stimulus. Okay, semantic loss. But he can name it without recognizing through this pathway. So that it is additional pathway which is shown here. So if there is a lesion in the associative pathway from the objects and the representative semantic field or the semantic conceptual field itself. In both the situations, they can name without recognition, as in our patient. So in our patient actually is happening is semantic lesion is here and not in the here because it could not recognize by palpation as well. So then next question, suppose both of them can present similarly. Visual associated agnosia and the semantic loss also behave the same. Both the things they cannot recognize the object. Now, how to differentiate between a lesion in the connection between the objects and their representation and the semantic field as here from a lesion there in the semantic conceptual field. Then how to differentiate? In one, you remember that the memory bank itself is intact, where the lesion, the true associative agnosia here, but here the memory bank is lost. So how to find out whether this memory bank is intact or not? If you look for the visual imagery, which is lost in semantic dementia, but not in visual agnosia. If you ask to tell him, can you tell the color of the sky? He'll be able to tell the color of the sky. That means, yes, that memory bank is inside. Only thing is the color is on. He could not say what color it is, what is it used for. The anatomy in the visual imagery is in the left temporal occipital region where the site of for the visual memory, the visual imagery is situated. So what is the patient having now? He has got a semantic dementia because he has difficulty in recognizing through more than visual sensory modality. And also he has got a single word comprehension problem because he could not understand the word meaning when I say the word meaning pen, but he by vision he is able to say the word pen. So this is the MRI of the patient showing gross bilateral temporal atrophy here. Bilateral temporal atrophy. Hippocampus is not affected much. So final diagnosis is a semantic dementia. So this case I bought only for an exercise to exercise the differentiating between the semantic, visual agnosia, semantic anomia, semantic agnosia, and the single word combination problem. I think you have a lot of questions here. I'll be able to answer. I can answer if you can ask me any questions. Any questions? The funniest
Sir,
part, yeah.
it's
Please.
a very difficult case, cognition. Now my question is that when we say semantic dementia, this can happen in any dementia like Alzheimer's dementia or frontotemporal dementia. When we use this term, only for this term, I wanted you to please tell us something.
Yeah, this is one type of frontotemporal dementia.
So yeah, that I know, but can it be applied to Alzheimer's or no?
Alzheimer's disease is not applicable to Alzheimer's, where the memory is lost first. Subsequently, they can develop these problems also. Everything can develop. But initially, these patients predominantly naming problem, single word combination problem. That's the problem they develop in this semantic dementia patient.
Okay. Just wanted to clarify. So frontotemporal dementia.
Yeah. Any other questions? I thought I'll be receiving a lot of questions regarding this. I don't know. The important thing is that initially when they saw the object, he named them, telling that his naming bank is intact. But when I showed the object, what is it? This is the pen. He cannot say that. That means he could not comprehend the word pen from a mouth, the verbally spoken. But that word is in his brain. That is, he said it is pen. That's the one important aspect in this patient. That is, initially he said correctly. That tells you he has got associated single word comprehension problem.
Sir, there are some questions for you. Can you read them?
Yeah. Please.
No, can you read them? Can you read them yourself?
No, I cannot read them myself because I am only seeing my screen here. Can somebody go and ask the call? Can you forward the question? Ask the questions to me. Maybe I think I'll be able to. I can see the questions now. Okay.
Yeah, you can read them and answer them, sir.
What is that? That is regarding the first case only.
No,
One
there's
next
a
case. Yeah. Coming to
there's a
the second one.
there's a question by Patty Francis. As the patient advances, how do you establish when they move in an Alzheimer type phase to use the medication for AD? I don't know whether it's relevant or not. The next question is, sir, can it be anomic aphasia?
Yeah, that's exactly an important question. The anomic aphasia is actually what is called, that is called normal aphasia or anomia, is inability to name. That means, make it very clear to you, is unable to name through any modality. So whether it's a visual modality or somatosensory modality or touch modality, he will not be able to bring out the name. The question is very, very valid in this patient because he was able to name initially by seeing it. That means he has no visual anomia. That does not mean that he has not, other anomia is not present. If he has shown the object subsequently, put the object in his hand, not only he did not recognize, he also did not name. That means he has got a subset of a visual anomic aphasia in the sense that he is not able to name through a somatosensory modality, but able to name through visual modality. This is called a modality-specific anomia. I know you said that there are 5 types of anomia. One is a word production type, word selection type, there is semantic anomia, or a modality-specific and a category-specific anomia. This is a modality-specific anomia, where he is unable to name through touch modality, but able to name through visual modality.
Sir, when he was naming this, when he named it first time, would he have known what is the use of this object? Would he have understood it? Although he named it, but did he know the?
That's exactly another good question. In fact, normally what we think that when somebody names an object, you recognize it. That's what that's the usual pathway we take about. We see the object, we have complete perception. We synthesize the features and recognize it, and then only go to the language area to name it. But in this patient, he could not recognize the use of the object. He could not use the object, but still he named it. That is why I have shown that cognition model, where I just for this. Where they can directly access the lexicon from the perception area itself without going to the semantic conceptual field. That's why I brought that.
I think that is very good concept. So one question is, how was his reading?
The reading part, he could not read at all. Reading is not able to do.
Okay, sir. Now one question is, it's a difficult question which only you can understand. Are there 2 fields separately for semantic and phonological identity?
Yes, of course. Both are separate. One is the phonological is a language area where you give it's a language function. On the other hand, the other is semantic aspect is the memory function. Semantics are stored in the medial temporal lobe or lateral temporal lobe, and there is as remote memory is concerned, mainly in the infralateral temporal lobe. Whereas other is in the language area. The phonological aspect comes only in the language. When you want, usually after recognition of the object, you give the name to the object. That is where the phonological aspect of it.
So the other question is, did he have tactile agnosia? It's a very difficult question also, sir.
I'll tell you. The problem is he had once there is the problem of whether he has got a visual agnosia plus tactile agnosia is possible. So we both things come together. That's what I initially said. You think of a more common place where both the things are lost together. That is a semantic story. Suppose you are not able to recognize through visual modality, through touch sensation, through auditive modality, through olfactory modality. All modalities you are not recognizing means the memory bank itself is lost. That's a more logical thinking. But you are right in the sense that somebody can have here anyway as contribution agnosia, he can have a tactile agnosia also. Both the things together is very well possible. That's what I initially my slide said. One cannot rule out the possibility of a coexistent visual and tactile agnosia together in this patient. But more logically, what happened if all the things are lost, the memory bank itself is lost. To differentiate that, only one way is that to find out whether it's got a visual imagery is present or not, which in fact I did not do that in this patient. These are all been the cases which when they already left the ward by the time my brain started working and came out of the diagnosis.
Yeah.
But your question
Madhu,
is valid.
Madhu, if a patient has for instance, this model which you are showing, that a patient can name one object without recognizing it, but he can name it.
Yeah.
Now, can he name all the objects or only some specific objects? For instance, if I give him pen, he will say it's a pen without knowing. But if I give him a book, will he say it's a book? Will I give him a TV? Will he say it's a TV? Will it be uniformly at that time? It will be retained, or it may be retained only for few objects?
What you said is correct. It can be all or it can be subset. But there are people who could not name for only inanimate objects or objects only. That's all subcategory is also possible. That's also possible.
Okay. Now, this patient, otherwise, I'm just curious to know, because he's your patient, you have seen him. Was he, at the stage when you were examining him, was he already grossly advanced dementia, or he was not? He looked like a normal person.
Absolutely normal person. Absolutely normal. He could carry out all his activities very well, look after his children, no behavioral problem, everything's perfect, except only problem is, according to the bystander, memory problem. But testing, these are the things which we got.
So what was his complaint with which he came to you? I just want to know.
The bystander has got a memory problem. So memory problem is quote unquote. That is everyone, they say memory problem. Actually, his problem was this.
Okay. So because of it, the attendants thought that he has a memory problem. Actually, he didn't have a memory problem.
Yeah, he did not have that.
Yeah. Thank you, Hara. This is a very, very difficult, I must say, but a very important case. Cognitive neurology, after all. Thank you, sir. Thank you, sir.
Just for the pages to know to differentiate between the various things. That's what I thought I would bring that case. Every time I'm bringing really peripheral neuropathy, peripheral problems and all. So I'll go to the next case.
Yes, sir.
Okay. Now, this is a story of a 60-year-old lady. 3 days prior to admission, while she was lying in the bed at night, she noticed burning pain on the right leg below the knee. About 4 hours later, when she got up from bed, she noticed mild weakness on the right leg. Next day morning, the weakness progressed, but was still able to walk with support. Next day, she was not able to move her right lower limb at all and got admitted. There is no weakness of the left lower limb or upper limbs, no pins and needle paresthesia, no root pain, no backache, no pain. She is not a non-diabetic, but found to have diabetes on the day of admission because she has never checked her blood sugar before. We do not know whether she was previously diabetic or not. This is the finding of the first day. An example. Like history. I'll go to the findings and then show the video. Let me see. Just 1 minute. Okay, this examination finding. Equilibrium is normal. Right flexor was weak, just against cavity. Knee extension was about 3+4, but that's also weak. Knee extension on the left side was normal. Left dorsiflexion was normal. Right dorsiflexion was weak. AHL was weak. Plantar flexion was good on the left side. weak on the right side. Main weakness on the dorsiflexion and right hip flexion. Knee flexion was weak, and knee extension, hip extension was also weak. The abduction was normal on the left side, weak on the right side. So in fact, all muscles are weak on the right side. More weakness was upper limb reflexes were normal. You can see. Lower limb reflexes slightly brisk bilateral. We don't know compared to the upper limb, it appears brisk. Angles were absent bilateral. Left was just elicitable, right was totally absent. It's a flicker of movement, but much less compared to that of the knee. Plantar's was indefinite. Sensory system, she said she's decreased pain on the right lower limb up to mid thigh on the right side. You couldn't hear it, but the vibration is also impaired on the right lower limb compared to the left lower. Left side was normal, that is impaired. In the iliac crest, shape is able to feel. Similarly, joint sense is also normal on the left side, impaired on the right side. Okay, that's a finding. I'll show the gait of the patient. No graphesthesia, he could identify the letter on the right side. No tactile discrimination either. Tactile discrimination could not be tested because we were not feeling touch very well on the right side. But number by pressure, he was able to tell the number. Gait, look at the gait. You could only walk with the support of 2 persons. Examination lower limb, tone normal. Upper limbs and findings are all normal, so I am not telling that. Weakness of all muscles of right lower limb, roughly grade 4, more for flexors of the hip and dorsiflex of the ankle abductors. Power of the left lower limb normal. DTR, knee check, brisk bilaterally. Angle check absent on the right side, decreased on the left side. Plantar indefinite. Sensory system, impaired pain up to the middle of the right thigh. Impaired vibration sense in joints in the right lower. So this is the any clarification of the findings I can tell. Weakness of the right lower limb, knee jerk brisk, absent ankle jerk, plantar indefinite, decreased pain and temperature, pain and posterior column on right lower limb. She came with a complaint of burning pain in the right leg, followed by difficulty in walking. Any thoughts? Where is a localization? What happened today? People are not asking questions. Last time, so many people were asking questions in between. Volunteering answer. Am I audible to you? Am I audible? Hello?
Yes, you're audible.
Okay. Yes, I'm just wondering, since no, and this is coming.
So I was seeing there are 2 responses from 2 attendees. One has said the localization is in plexus, and one is taken the localization to the medulla. So totally 2 different localization.
Okay. Right. Any other localization you want to post?
And one has written cerebral cortex.
So logically, see, when you get loss of pain and say posterior column on one side, the lower limb alone, either, so we don't know that there is weakness in abdomen and UMN. So that means it could be either in the right-sided plexus, right-sided caudate vena, that's possible, or it should be in the lesion above the medulla on the left side, when the left medulla or left brainstem, left thalamus or left cortex. Because after crossing the both sensory pathways, then only you can get the same side lesions. Now the question is, okay, these are the possibilities. Now, what do you want now? What do you want? Cortex. So we do not know whether lesion causing weakness is the LM ligament. There are some point favoring, some favoring. Knee jerk appears to be brisk, but that is bilaterally brisk. Angle appears to be absent, whether we do not know whether it should be the diabetes. And plantar is indefinite, again, that we cannot give a clue. So it is difficult to find out even whether weakness element UMN in this patient. Okay, you're right. So we have to, if UMN, and why should we consider UMN? Because the right knee jerk is brisk in the weak muscle. That's a point. It's got a weakness is there, it's still brisk. That's one point you have to make it think a possibility for UMN. The absent angle jerk could have been due to undetected diabetes, since it is absent on both sides. That is one way of thinking about it. Now, why not element? That's also another possibility which you have to think. Again, the only odd point is that this knee jerk is slightly odd, but you can see it's the evolving phase. That is why it's not. But the point is that even with good power of the left foot, that reflexes become absent. But with weak muscle on the right thigh has not become absent. So there again some problem in accepting that argument. Now, what is it? Thoracic cord? You cannot be explained by the pain and posterior column on the same side. So cortical left thalamic capsule lesions or middle is possible.
Madhu, can I make a point here?
Yeah, please.
You know, I mean, if we have sometimes, let us say theoretically, if it was a L5S1 lesion because the ankle jerk is absent, in that case, many times the knee jerk can become brisk because of the lack of the antagonistic muscle. But that will not apply here because his thigh muscles are also weak.
Correct, exactly. Yeah. Because quadriceps is also weak, hip flexion is also markedly weak.
Yeah.
So that makes it a little odd because it's.
Otherwise, you can have sometimes brisk knee jerk even though there is no disease there, just because.
Yeah. Normally, also, perfectly right. Can be constitutionally brisk reflex. That's a possibility. The only thing is the upper limb.
No, in the absence, in the presence of a absent ankle jerk, the knee jerk can become brisk.
Yes.
Yeah.
But the problem we thought by knee jerk is slightly brisk because the upper impulse was not brisk. They just
Correct.
So there may be a pyramidal lesion. I'm not very sure about that. But it's little difficult to differentiate. That's the point I'm trying to say. The element lesion could be a possibility. The lesion can be the epiconus extending from the L2 testament on the right side, involving the anterior console. That's a possibility. But again, the problem comes difficult to explain the loss of pain in posterior column on the same side, correct? Just like it's a cord. Cord means it should have a dissociated sensory problem. Loss of posterior column on the same side, loss of pain on the opposite side. Or a caudate lesion on the right side. These are the things you have to keep in mind. This can explain the loss of pain in posterior column on the right side. So what investigation should you require? First, CT scan of the brain, normal. Come on, you want MRI? Okay, MRI brain was done, normal. No lesion in the hemispheres, thalamus, or in the medulla. Diffusion normal. So in fact, we're seeing that MRI brain normal. So, and since the right finder was not going to suggest a typically pyramidal lesion, I did a nerve conduction study also in this patient found to be normal. Now, what else you want at this point of time?
EMG was also normal, Madhu?
Pardon?
EMG of the muscles. Needle.
I did not do because I was two possibility was plexus versus quad equina. The plexus thing I thought I will do NCV, which was normal. And EMG also initial phase you may pick up only later on because it happened you're doing it the first week. The investigation, the EMG findings will appear only later on in the course after 2-3 weeks.
This was the acute onset illness.
Yeah, acute onset. I did it probably on the 4th or 5th day. So what else you want?
Somebody wants MRI of the lumbosacral spine.
Okay. Lumbosacral spine was normal. I don't know whether it is with me or not. Okay, it was normal. You want thoracic spine cord or not? Nobody wants thoracic spinal cord? But I did a thoracic spinal cord. This is thoracic spinal cord. After brain, I wanted this thing for the reasons I will tell later on. That is normal.
They want MRI pelvis.
For the plexus.
Pelvis, yeah.
Yeah, to find out lesion of the plexus. So yes. I did not do that because NCV was normal. So I thought that's a possibility. We should have done that. But diagnosis was there even before that. Without the MRI pelvis. I did not go for the MRI pelvis. Okay. Now let's see what has happened to the patient. On the second day, she complained of mild weakness in the left leg. Left was just elicitable, right became absent. Plantars remained the same, sensory findings remained the same. So, moderate weakness left reflexes and mild weakness hip abductors, distal muscles of the left leg was normal. DTR, right knee jerk, which was brisk earlier, became absent. Left knee jerk was less compared to the first day of examination. Both angle jerks remained the same. Rest of the sensory findings remained the same. Now the question, now we know its lesion is the element lesion and not the human lesion now. Because the overt point initially was the brisk knee jerk, which has become now absent. Now, is it cauda equina or is it epiconus lesion? That's the next question. The fact that pain in posterior column lost on the same side favors a cauda equina, but the brisk knee jerk, the significantly affected muscles are not the first one. Epiconus, the brisk knee jerk can be explained by the associated pyramidal lesion. How to explain the loss of pain in posterior column on the same side? Agree? There are points for and against. In the cauda equina, the reflexes become absent. It can be explained by the right side of the lesions. That can explain the loss of pain in posterior column on the same side. But the odd point is the brisk knee jerk, which has occurred earlier with weakness, that's against the cauda equina, but now he has become absent. That means it's a progressive lesion. That way you can argue about it. The epiconus lesion, the brisk knee jerk can be explained because associated pyramidal lesion can be there. If the lesion is above L5, you can associate pyramidal involvement and can brisk knee jerk. But how to explain the loss of pain in posterior column in the same side? So which one of you vote for? You will vote for cauda equina or epiconus lesion? Now we know it's a lesion is LMN. Knee jerk became absent. Which will you vote for? Participants, any audience? Right, today people are not giving anything. Last time everyone was voicing out their opinion. Okay, if no answer, I'll tell you what I did. This is MRI of vote for epiconus lesion. As reason I will tell you later on. This is the lesion in the epicornus, the long extensive hyperdensity, the epicornus region from the D9 downward up to D11, up to L3, L4 is S1 itself is the hyperdensity. You can make out hyperdensity here, extending up to the cornus region, up to the S1. You can see the hyperdensity. And the lesion is in the cord, inside the cord hyperdensity, which is more on the right side of the cord, D11, D10, and the cornus region is also hyperdensity, right side. This is the finding on the 5th day. The findings remain the same. And you get the main findings also remain the same. Now, epicornus lesion. Now you want to ask me a question. Why should you, how do you explain the pain and posterior loss on the same side, correct? In fact, her lesion might have affected the right side of the cord from L3 to S1 on the right side at the very beginning itself. The reject was this initially because of the coexisting pyramidal involvement. How to explain the pain and posterior sensory loss on the same side? So further, have you ever seen this book, Bing's Local Diagnosis in Neurology Disease? When I was studying, this was the only two books, neurology books available where one is the Raymond D. Adams, other was the Bing's Local Diagnosis. There was no other neurology textbook at that time. And subsequently came the Patton's book, and Bradley came much later. When I was completing my DM, then that came. So this is the book, which is a very good book for clinical diagnosis. See, hemicord lesion need not always produce Brown-Sequard syndrome. This picture is from that book. So what happens is that, if we pain and temperature fibers, as you all know, when you enter the cord, they ascend for few segments, then only cross to the opposite side, correct? And the slant, the ascent is least in the lower thoracic cord. Forget about the picture here. Least in the lower thoracic cord, they ascend only 1 or 2 segments. If you become upper thoracic cord, it becomes 2 to 3 segments. So meaning thereby that if you got a lesion at D8, you can have sensory loss only at D9. If it is a lesion at D1, you can have sensory loss only at D3, D4. And little more slant will be there in the cervical cord. So it has 4 to 5 segments when you reach cervical cord. So if you lesion at C1, you get a sensory loss only at C4, C5. So because of that, as the pain fiber enter, they do not cross immediately, ascend for a few segments and cross. That's the usual pattern. But the greatest slant is not in the cervical cord, but in the lumbar cord. That's the point you have to keep in mind. And secondly, all the segments are stacked closely in the lumbar cord. So what happened means they are very close together. So this picture shows the slant of the crossing fibers. So what happens is that here the individual segments lie close together, so that only a few crossing spinal fibers passing caudal to the lesion reach the opposite side. So slant of the action fibers is maximum in the lumbar cord. So what happens is the lesion here is going to cut off your pain and temperature fibers, which is going to cross, as well as the posterior column, which is on the same side. That is why you get the same loss of pain and temperature and posterior column on the same side of the epicornus lesion. In fact, I have seen many cases where the following spinal anesthesia, for example, cesarean section and all, they can come to with weakness of one lower limb. And you find that weakness is on the same side, and the pain and temperature, everything is on the same side. And you find a lesion in the lower lumbar cord on that side. You are going to come across such cases in future, because this is a very common problem. This is how it is explained in this picture. ND-MOG and NMO was not done, and patients put on IV and improved almost totally in 1 or 2 months' time. So this is a story. Any questions on this patient?
So what was the etiology here? Localization is okay. What was the etiology?
Etiology most likely demyelination, because improved totally with this thing. CSF was normal. Anti-MOG could not be done because at that time anti-MOG was not available. It's not come into the literature so much.
So what you're saying that as opposed to a typical brown sequoia syndrome here, you showed that there is a posterior column and spinothalamic on the same side.
Same side.
Now, is that because of this particular location? Suppose if the same thing, can it happen if there's a lesion in thoracic cord also, or no? It will happen only at this site.
Only at this.
Phenomenon.
This cannot happen in the lesion thoracic cord or on the cervical cord.
Yeah. I think that is the point. Take home. So, but Madhu, in the first MRI which you showed, was it visible from the very beginning? Because
in fact, it was from the very beginning, sir. I was only, I tell you.
Yeah, because what you initially showed that as if it was normal, but actually it was there. Huh?
It was there. It was a little bit. See, look very carefully. This is thoracic cord. If you look at the deep, then you can find the hyperdensity here. This is the picture I shown you earlier. This only to make you.
Yeah, I mean, yeah, we can, yeah. So we have to look at the MRI also very carefully.
Yeah, that's it. Nobody said they will look at the lower part because even this was suspected initially itself. That's why we do not go for other pelvic MRI now.
So was it a contrast MRI?
That's not a contrast MRI.
Okay, so in plain it was,
Plain
but difficult. I mean, it is not coming out. It is not strikingly coming out. You have to really.
It is coming out now. So I think I'll show you once again.
Okay, please.
Yeah. See, the hyperdensity can be made out here. This is the lumbar cord.
Yes.
Here also you can make out the stir images.
Yeah, exactly. Yeah. Here it is very clear. Yeah.
Here also you can make out the axial section. I will show the axial section. You can see the hyperdensity here. Here also you can see it on the right side. You can make it out here on the right side. Left side of the cord was not better. Also,
it's intraaxial. It's an intraaxial lesion.
Intraaxial.
Spinal cord lesion.
Correct. Okay, any questions on that thing? So, in fact, what happened was that, see, remember in epiconus lesion, you can have a combination of both LMN and UMN. But UMN occurs only if the lesion happens to be above L5 segment should be affected. The lesion is at or below L5 segment in the epiconus or on the conus, you will not get any pyramidal signs because you will not get the upper implant. If the lesion is at L5 S1, you may get an UMN bladder, but pannura will not be upper. The lesion happens to involve the conus, of course, you will get only LMN bladder. So the way to diagnose a lesion in the epiconus above S234 only by the presence of a UMN bladder, and if it happens to be above L5, you may get non-pain panda or biscuit depending upon where the site of lesion is.
Her bladder was involved?
Here, it was unilateral. That's why bladder was not involved in this. Even after complete weakness, bladder was not involved. The MRI was taken initially. Subsequently, after the patient progressed, I did not repeat them. Okay.
Now, what is coming to my mind is that because it was in that lower portion, she might be positive for MOG.
Exactly. The picture was also very much like anti-MOG antibody.
So, are you in touch with this patient? Is she?
No, she improved totally. Once they improved, they will not come back. No, they improved totally. She never came back.
So, but I'm suspecting she may come back to you again after some time.
Okay, shall we close it today? It's already I had taken 1.5 hours time.
Okay, Madhu. Thank you so much. Much of learning. So much of learning from you.
Thank you.
Thank you, sir.
But people are not asking questions today. That's
no, I don't know. Mansi will have to look it because I don't know. You are not able to read the questions. I'm able to read the questions. I don't know what that is the technical part of it that I think they will see.
No, in fact, they were asked to unmute themselves and answer questions in between regarding the localization, the clarifying doubt. Then only it can become interesting.
Yeah. Thank you, sir.
Thank you. Thank you.
Thanks.